I'm Leo Gordon, and from Northwestern University Feinberg School of Medicine and the Robert H. Lurie Comprehensive Cancer Center. And John asked me to kind of review with you current approaches to Waldenstrom's macroglobulinemia. And what I think I'm going to do is try and do briefly a clinical overview of the disease, talk a little bit about various forms of IgM gammopathies, and also talk some about when treatment might be indicated for this group of diseases. And in that discussion, I think we will talk some about the biology and specifically try to talk about MYD88 mutations and CXCR4 mutations and the role that they might play in treatment decisions, the diagnosis, and how we might approach patients with Waldenstrom's at the bedside. I will talk somewhat about clinical trials, and I think focus first on some of the standard chemotherapy trials in patients with Waldenstrom's, and then spend a little bit of time on some the newer aspects of BTK inhibitor therapy, talk about some of the Ibrutinib studies that Steve Treon first presented back and published back in 2015, and then also talk about the current study, the Aspen, so-called Aspen trial, comparing Ibrutinib with a new generation, call it second or third generation, BTK inhibitors and Ibrutinib, and talk about some of the ins and outs and positives and negatives of these trials. So first, a little bit about the biology, and I consider the clinical features to be part of the biology. I consider what happens at the bedside to be the biology, just as much perhaps as what happens in the laboratory, in the molecular biology laboratory and the genetics laboratory. So first of all, there's a spectrum, and this was presented by Ms. Rajkumar et al. Back in 2006. Looking at the spectrum of IgM disorders, there are patients with who have monoclonal gammopathy of undetermined significance with IgM, and those are patients that generally have less than 3 gram per deciliter of serum IgM, so small paraprotein, less than 10% marrow involvement with a lymphoplasmacytic lymphoma, and no end organ damage. Then the next, and that's a group that we think can be observed without any intervention. Then there's patients with asymptomatic Waldenstrom's. They might have, again, still no end organ damage, bottom line there, but greater than 3 gram per deciliter serum IgM, or greater than 10% marrow involvement. And then, again, a group of patients that I think can be observed at the time of diagnosis. And then those patients that might require treatment, this says start treatment, but I think there are some fine points there that we can discuss further, which patients might require treatment. So any size paraprotein, I guess, greater than 10% marrow involvement, and end organ damage. And so that's where some of the fine tuning comes in, what you consider to be end organ damage, how severe that end organ damage is. Does that include anemia? Does that include peripheral neuropathy? So I think those are all questions that come to mind. The other one that comes to mind, I think we've had at the bedside some issues making the distinction sometime between Waldenstrom's macroglobulinemia and maybe marginal zone lymphoma that happens to have an IgM paraprotein. And we tend to rely on the MYD88 expression now that can be measured routinely in any molecular biology laboratory. It's available clinically to everybody. We know that upward 70, 80, 90% of patients with Waldenstrom's will have a MYD88 mutation, and most patients with marginal zone lymphoma, 70, 80, 90%, don't. However, there's still some overlap there. There's still a small group of patients with Waldenstroms that don't have an MYD88 mutation, and some patients with marginal zone that do have a MYD88 mutation. So I think that's something to keep in mind as we go through this. So this is an international prognostic scoring system for Waldenstrom that's predictive of survival, age greater than 65, hemoglobin less than 11.5, platelets less than 100,000, a beta-2 microglobulin greater than 3, and a serum M protein of greater than 7 gram per deciliter, and an elevated LDH I would include as an important prognostic factor. Those with low risk, less than 1 adverse feature, or less than or equal to 1, or an age less than 65, have many years median survival, 142 months calculated. Those with intermediate risk, 98 months, and even the highest risk category have a median outcome of about 43 months. And these are data published in 2008, 2010, prior to the use of some of our novel treatments. And if you look at the importance of MYD88 and CXCR4 and overall survival, Steve Treon presented this in Blood in 2014. What you can see is those patients with wild-type MYD88 and wild-type CXCR4 have a worse outcome. And those patients who have a MYD88 mutation with wild-type CXCR4 in red maybe do the best, and those patients who have MYD88 mutation and a CXCR4, so-called WIM mutation, may be similar, or maybe a little bit better for 15 months and then drop off. So there's some variability, but I think importance of those mutations in the outcome of patients with Waldenstroms. We think frontline therapy still should be investigated. There are conventional chemotherapy approaches, like cyclophosphamide, bendamustine, fludarabine is active, cladribine is active. I think these are not used much anymore. Monoclonal antibodies, either ofatumumab or rituximab. I don't think that obinutuzumab has been investigated to any great degree, but maybe should be. And then a BTK inhibitor, Ibrutinib, and this will be the subject of some of what we're going to talk about. Proteasome inhibitors still have a role. Bortezomib, carfilzomib, and ixazomib as the oral proteasome inhibitor may have some role to play and probably can be studied in clinical trials. This is a presentation by Dimitopoulos and Kastridis in Blood in 2019. I just want you to focus on the top line of this in terms of making a diagnosis. Lymphoplasmacytes or lymphoplasmacytic lymphoma under bone marrow biopsy, cytogenetics, often a deletion 6q, anywhere from 30 to 50%. As I said, the MYD88 L265P mutation in 70 to 90% of patients. And the immunotype is shown here, a typical B-cell population. These are CD20 positive and strikingly positive. There may be some plasma cell population present as well. Clinically, patients may have no symptoms, or they may have hyperviscosity, lymphadenopathy, splenomegaly, and neuropathy. So I think that's worth focusing on. And then their data presented. This is from work by Yang et al. In Blood in 2013 and 2016, looking that pro-survival signaling is driven by the MYD88 mutation in Waldenstroms, probably with a role on hematopoietic cell kinase and Bruton's tyrosine kinase mediated by MYD88. Ultimately, though, leading to NF-kappa B initiation and production, leading as a pro-survival signal or a negative signal for tumor survival, if you will, for patient survival, a good signal for tumor survival. And so that's that's probably the mechanism of this whole pathway and why that might be so important. And there are data that MYD88 mutations transactivate the pro-survival factor NF-kappa B, and that's shown in these data here by Steve Treon, presented this in the New England Journal 2012, and in Nature by a group in 2011, that you get an increase in NF-kappa B luciferase after MYD88 mutation. So interesting data. Also, WIM-like, so-called WIM-like CXCR4 mutations in Waldenstroms have been described, and they're probably also important. The most common mutation is the so-called S338X mutation that also drives tumor growth. So this is from the How I Treat manuscript. I think it's worth reading for everybody in Blood in 2019. At the time of diagnosis, immunophenotype and some genetic studies, especially the CXCR4 and MYD88, a bone marrow biopsy, and look at the clinical presentation. Those that are not symptomatic should be followed. Those that are symptomatic, you have to decide about need for immediate treatment, comorbidities, patient's preferences, and then you have to decide on whether you're going to do a fixed duration chemoimmunotherapy versus continued therapy. And I think we don't know the answer to that question yet, but that's what we're going to talk about. So I think we can talk about there's some clinical indications for initiation of treatment: hyperviscosity, fever, lymphadenopathy, etc. There's some laboratory indications: symptomatic cryoglobulins, cold agglutinins, autoimmune hemolysis, perhaps neuropathy, low hemoglobin, and low platelet count. Now, what clinical trials are there, and how should we approach treatment for patients with Waldenstroms? First publication, I think that's important, and this isn't necessarily the first treatment, but some of the more recent data was presented by Steve Treon, looking at the BTK inhibitor Ibrutinib. They looked at MYD88 and CXCR4 mutation status as a predictive factor, but these patients got treated with 420 milligrams a day of Ibrutinib, and either to progressive disease or unacceptable toxicity was stopped. But if patients were responding and or had stable disease without toxicity, treatment was continued indefinitely. The first patient was treated in May 2012. Median time on treatment was 19 months at the time of the original publication, and the update, which was updated in Lugano last year, the median time to treatment was 47 months. And the last patient follow-up was, the data lock was October 2018. And this just gives you some sense of what happens to, in a big picture, to serum immunoglobulin levels. They go down dramatically through cycle 21, and hemoglobin goes up dramatically. If you look at the updated data, the best IgM response was from 3.5 grams to 820 milligrams, and the best hemoglobin response was 10.5 gram up to 14 grams. These are the updated data from Lugano in 2019. If you look by MYD88 and CXCR4 status, if you look at the MYD88 mutated patients only, 5-year progression-free survival was 71%. Patients had no mutation of either MYD88 or CXCR4. It was poor. And if you look at the MYD88 MYD88 and CXR both mutated, it was 34%. So it looks like in this study, the MYD88 with Ibrutinib, the MYD88 mutated only patients did the best. Interesting data, and makes this an active agent, and certainly an approved agent now for the treatment of Waldenstroms. Ibrutinib is highly active in relapsed and refractory Waldenstroms, not as upfront treatment yet. Wild type show no major response in early disease progression, and MYD88 mutated patients with CXR mutations show longer time to major response, less depth of response, and earlier progression versus CXCR4 wild type patients. If you look at some of the clinical trials, this is presented by the Mayo Clinic group, comparing bendamustine Rituxan, dexamethasone Rituxan and Cytoxan, and a proteasome inhibitor, bortezomib, dexamethasone, and Rituxan, as first-line treatment for Waldenstroms. These are the regimens, randomized 3-arm study, DRC, BR, or BTR, if you will. And if you look at the bottom line on this study, if you look at the green curves, progression-free survival is Rituxan bendamustine, event-free survival, Rituxan bendamustine, and time to next therapy, Rituxan bendamustine. There is no difference, however, and this speaks to the good options for second and third line treatments in this disease, no difference in survival despite the better progression-free, event-free, and time to next treatment benefit. So I would say that based on these data, one can argue, and the Mayo Clinic group did, that bendamustine Rituxan might be their first treatment approach. And then finally, I'm going to look at the Aspen study. This is results of a phase 3 randomized trial of zanubrutinib versus ibrutinib for patients with Waldenstrom's. This was presented at ASCO virtually this year by Konstantin Tam and the group with a large number of investigators. And basically, zanubrutinib is a second or maybe third generation now BTK inhibitor that has less off-target effects and leading, we think, to perhaps, at least the thought is, less secondary side effects, less hypertension perhaps, less atrial fibrillation, less bleeding. And that really was the question. Is this a better approach in patients with previously treated Waldenström Macroglobulinemia? They looked at really two cohorts of patients. This was the MYD88 mutated patients. 164 of the 201 were relapsed refractory. They also had a separate cohort, I didn't show that here, of patients with non-mutated Waldenströms who were just treated with zanubrutinib. This study was randomized 1-to-1 ibrutinib and zanubrutinib, 420 milligrams a day and 160 milligrams twice a day, which is the recommended phase 2 dose, both until progressive disease. If you look at the progression-free survival and overall survival, really no striking differences between the two. CR, if you look at the response of a complete remission plus a very good partial remission, zanubrutinib was a little bit higher, but not statistically significant. So no major differences there. I think, however, if you look at the toxicity, this is where adverse events come into play as maybe the more important factor. Here we see, if you look on the left, muscle spasms, peripheral edema, hypertension in red, atrial fibrillation 14% versus 2% with zanubrutinib. Neutropenia was more common with zanubrutinib than with ibrutinib, but pneumonia, diarrhea, many of the significant, I think, side effects that we might see with ibrutinib in long-term treatment are not present with zanubrutinib. If you look at overall at an adverse event leading to discontinuation of therapy, 14% with ibrutinib and only 4% with zanubrutinib. And if you look at on the right, the KM curves time to atrial fibrillation or time to hypertension, zanubrutinib is in red and the ibrutinib is in blue. So this is what we've come to expect with long-term treatment with ibrutinib, and it's something that we may see an advantage here for zanubrutinib. And so if you look at the conclusions of the Aspen trial, they're summarized here. If you look at the primary endpoint, superior complete response plus very good partial response was not met. There's a trend to improve deep responses with zanubrutinib. Deep responses may improve over time. There's a higher risk of cardiovascular toxicity with ibrutinib. So in favor of zanubrutinib is less atrial fib, less hypertension, less muscle spasm, less edema, less discontinuations for adverse events. In favor of ibrutinib, once-a-day dosing rather than twice-a-day dosing, and less neutropenia. And so how would you come down on this? First of all, the drug's not approved, but if given the choice of FDA approved, one could make a strong argument to favor zanubrutinib in this trial. So this might represent a significant advance. I think it's going to take more time and more data to show that those differences hold up. So I think at this point we've reached the time. We've talked about a clinical overview of Waldenstrom's at the bedside and in the laboratory. We've talked about the biology at the bedside and the laboratory with MYD88 and CXCR4 is important. And we've talked about clinical trials with standard chemotherapy drugs with bendamustine Rituxan as sort of the winner, if you will. And we've talked about some of the important trials, especially the initial ibrutinib trial by Steve Treon and then the so-called Aspen trial by Constantine Tam, suggesting maybe an improvement with zanubrutinib over ibrutinib. So I think at this point I will stop, and we'll be able to take questions in the Q&A session. Thank you very much.